because when they look up the national figures, there's a study there that was done in 2010, and it was released in 2013. And when I am asked, and patients look up themselves, the number there, it says 113 per year. So what we need to do, I think, as a patient group and a team together, is to get new figures. How many patients are diagnosed every year? So patients can look up themselves. We also need to break it into categories. So how many are lung, how many are pancreas, how many are everything like that. So patients can have this information. And I mean, what we feel is knowledge is power. So if we could all work together, that we could have some new figures done, because everybody that looks up is 2010 the study was done, 2013 it was released. And is that something that we can work together to get organised?
Yeah, I might take that. It's Mr. Oriel, the NCB lead, who unfortunately had to go because his son is doing a fiesh down in Killarney. He's a great musician. Yeah, great for him. But Andy, the question is very nice, because the data will be re-actualized hopefully next year, because the cancer registry has all of the data in terms of so every cancer that's actually diagnosed in Ireland is officially registered through all the pathology laboratories in Ireland, and the cancer registry re-actualizes those figures not often enough. But we've actually requested from the registry that we update the figures, so it would be nice, and we'll hopefully have that. We'll hopefully have it by this time next year. It'd be nice to have that. Fully agree.
Just one other thing. There's no doubt that neuroendocrine tumours are rising very rapidly. Whether that is the case, that we're picking them up more, but I think you'd agree, Dermot, that it's actually a global, particularly in the Western world, a global problem. There's almost been a 6-fold increase in neuroendocrine tumours in the last 20 years. So that does need to be picked up, because I think, again, in terms of resource allocation for the future, we spoke about gallium, PET scanning, and so on. That type of planning for the future is very important.
And if I can just, on a strategic level, the HSE is moving away from registries for different diseases, and they're trying to establish what they're calling a big data kind of analysis, where, and some of you will know that you're being routinely called to your GP now for chronic, over the age, I think, 55, for screening, and for, and that's all being entered into a database, along with the list of conditions that individuals have. And there's a move now underway that we will all have a unique health identifier number, and legislation is progressing that will be our PPS number. And in 15 years' time, it is hoped that the HSE will just be able to extract all that data from a massive, kind of, if you like, health database. Because it's expensive to set up individual registries. We've been looking for a register for diabetes forever, since I came back to this country, and we still don't have one. So that's the strategic move over the next 15 years.
Sorry, Catherine is back and will join the panel now as well. So Catherine's from the Treatment Abroad scheme. I did put that question to Rishtard before he left. It was just about the National Cancer Registry, I think it was number 36, that he did in 2013 on neuroendocrine tumours, and he said he'll raise that as well with the National Cancer Registry Ireland about refreshing that, and hopefully we do have about this time next year, which would be wonderful. So, next question. Okay.
Sorry, thank you. I'm a net patient based in Dublin, and I'm just querying access to A&E as a net patient, just in terms of priority access. My local hospital is St. Vincent's. I had a recent incident where I was waiting for over 10 hours in terms of getting care as such. So just wondering, is there any plans to prioritise our access to A&E?
The answer to that is I would love to say yes, but I would say yes then to patients with pancreas cancer, patients with bowel cancer, patients with so many other types of cancer. The health system is on its knees in many ways, in particular for acute access. I work in the Mercy University Hospital, an inner city hospital in Cork. And because of the specialist service that we run, we get referrals from all over Southern Ireland, so from Limerick, from Kerry, from County Clare, from Kilkenny, Wexford, Waterford and Tipperary. And very frequently I'll get a phone call from a consultant to transfer a patient who's in a hospital to my hospital who's got a neuroendocrine tumour or any other of the diseases that I deal with. And very frequently I can't admit that patient directly from one hospital to the other. They have to come in through the ED department, which is ridiculous. They're coming from a hospital to an ED department to be admitted. But there is a shortage of beds, and I just think that it's going to be very difficult to prioritise and say, I've got a net card, I'm a net patient, I've got to get a bed straight away. I don't think that's going to be possible.
Yeah.
I would love to say yes. I think we should have no patients that are waiting 10 hours in any ED department. But if you come into my hospital in the Mercy, and indeed most hospitals, Cork University Hospital, where I also work, it is inundated with patients with all sorts of diseases and all sorts of conditions. And the prioritising or the triaging of those patients that takes place in ED often takes place at a very slow pace. So patients who are coming in with a dog bite are often waiting just as long as someone who's coming in with a more serious condition, recurrence of a NET or a problem like that. So there's no simple answer to that.
And I totally understand that. I suppose just for the room, when I put this on Facebook, actually there was feedback given from many of the patients in the room that in UL, in Limerick, in University Limerick Hospital, they can actually access through oncology. So that was really the purpose of the question, to know whether that could be expanded to Vincent's or not. Totally understanding the ED issues.
It depends on the oncology service as well. I know that in James's, where I also work, we used to have access for certain oncological semi-emergencies, and they would go directly to the oncology ward. Even that now has been stifled in terms of being overrun. And just to sort of think also, just non-selfishly, that there are many rooms around the country where similar networks of other cancer groups, whether it's breast cancer or colon cancer or whatever, where people are thinking the same way, and certainly was empathise with that. What I would just suggest is that when possible through your NET centre, to contact the centre during working hours, of course. It doesn't always mean that you can sort of get in. And elective admissions, for example, to a public hospital in general is very hard. Sometimes if people have private health insurance and we're going private and public, and lots of you have private and public, and that's the reality, And sometimes we can get people into a private hospital and then transfer them to the public hospital, if they need a specific thing that we're doing in the public hospital as well. So that's part of the overall system, as Christo was saying. It's really hard. But and I can't see it getting easier. And I don't know if Sloan Chikera is going to help that either, to be honest with you.
If I can just add to that, then the public hospitals in Ireland at the moment are running at about 115 to 120% occupancy, right? Because hospitals can't turn and don't turn people away. Think about Ryanair or a hotel having 120% occupancy and the chaos, right? So de facto our acute services are chaotic at the moment, and that's a problem. But the people working in the system are doing their best, and Ireland, big picture, has a good healthcare system, with access being the problem. We have to accept that is the environment that we're working in. When you go as a NET patient to an emergency department, it means you're sick, and the most important thing is that you let the people that are triaging know that you have a neuroendocrine tumour, and if you're a kind of carcinoid individual with your card, you give that and make the people aware of it, because there is a risk that you will be 10 hours waiting, and that you may not be seen for a number of hours, and you reduce that risk if you highlight that you have this particular condition.
Could I just add a patient dimension to that? I know where you're coming from. I can also tell you from our role with this organisation, I'm on to some of the clinicians you see in this panel, sometimes late at night, and I was on to Christopher, for instance, twice in recent times at 7 or 8, 9 o'clock at night, and he was scrubbed and he was going in to carry out emergency surgery. So they're under awful pressure too. And I wouldn't like that pressure that they're under, I wouldn't like that to take from some other important information for us, patients. And that's in relation to our desire to see improved nursing services in the nurse, in the NETS network as a point of reference and a point of expertise. And there are very real plans to try to improve the net nurse situation, and maybe Dermot, you might have a word or two in relation to that, because we discussed it before about maybe just trying to improve the nursing situation, the numbers of nurses available, the number of nurses who have an expertise in nets who might become part of the system.
Yeah, well, we have 2 new nurses, for example, in the PORT. So, I mean, for those who have got PORT-specific issues, that will be a good point of contact. It's going to take a little bit of time because one of them were both radiology trained initially. You know, you get people, it's hard to get, it took a long time for us to recruit those, over 18 months, gee whiz. It was 6 months for the first one. And yeah, we have them there and they're very nice and it's worked. And Hussein has been sort of leading them in terms of education around the PRT therapy. And now we've also trying to get them involved in overall education of NET so that they become equipped with all aspects of NET. And that's a very important point. We were just talking about that with them yesterday. That'll take a little bit of time. But I would also, in our own centre, I would hopefully, over the next, maybe 24 months, have an additional full-time person. We're aiming for that. Now, we've got a good bit out of the NCCP already with the funds to had 2 new physicians. We had nuclear medicine, therapy specialists and stuff like this. So that all costs a lot of money. But can I also add that Christopher and I, we went out last night, actually, and it was really nice because we haven't met up for a long time. But we were talking about bolstering the service as well in Cork and trying to get that as well, because Christopher and Derek and colleagues down here and their multidisciplinary team are working on a shoestring as well. So certainly as national lead on the NET Groups lead, my priority at the moment in terms of extra administrative staff and clinical nurse specialists would be Cork #1, because we have a little bit of leeway with respect to that. Hussein is there as well, and we have Jerry, for example, our coordinator in Vincent, who does a Trojan job when people call in, etc. So we filter out the calls to either Ahmed, who can't be here today because his wife was unwell, unfortunately, would have lovely to introduce you. He's a lovely guy. Ahmed, and of course Hussein or Rachel. And we've got a big team, relatively big team in Vincent, that we can try to feel that out. But Tommy, we were trying to do that. There are improvements, I think, on road for us, but we want to prioritise Cork now. And, you know, we haven't even spoken about Galway, something that I mentioned as well that I'd love to take, because Galway are not represented here, and I think it's really important that Greg Leonard and Marcia Bell and the colleagues there get a real shout out. They're fantastic friends. They've got a big catchment area as well. And I put it to Mark and to Tommy that I'd love to take this group to Galway, because I think it'd be nice to embrace people, and some people who can't come down, but it's something that you might consider, because they're great friends.
I have one question. Christopher first. Why wasn't I asked to that dinner last night?
There was only 3 seats available in the restaurant. That's the problem. It was myself, Derek, and Dermot, but I'm sure we can make up somehow. Tommy's got an answer, I think, as well. Tommy always has an answer.
Well, you'll have to eat to go to a restaurant, and you never eat, as we know.
I think
I unfortunately eat too much.
I think we'll take that on board, Dermot, about Galway. I think it is overdue, but as a committee we'll talk about it and hopefully do that. Helen has a question in the corner. Follow up to the last question.
Hi. Just relating to the net nurse, my question is the access and the availability of the net nurse. I'm aware at present that Thursday and Fridays appears to be like a part-time net nurse with Lisa. However, the frustration, especially as a patient, is when you need the contact Monday to Wednesday and there's no availability there. and you just get the automated reply. Is it something in the future that the full-time net nurse will be available?
Sorry. So as Dermot mentioned, this is in progress. Oh, sorry. It's in progress, but meanwhile, since I started as a full-time since May, so I'm available 5 days a week. We also, as Dermot mentioned, we have a net fellow who's available as well during weekdays. I know you used to, you always contact through Lisa personal email, but there is a net general net center email that you could use, and this will be looked after 5 days a week, and there's a number to leave a voice message anytime, and this will be looked after as well 5 days a week. So even if Lisa is not around, the rest of the team will be able to answer your question.
Is that on the St. Vincent's website? And can we get it? Okay.
It is on the website, actually.
Okay.
Yeah.
Oh, we should put it onto our
But
website
maybe you
as
should
well.
put it
Yes.
on the website, the net general email.
Okay, any next question? Okay, please go ahead.
First of all, I have to thank Prof. O'Shea, Prof. O'Toole, Ahmed, and the team, and Tommy, and Treatment Abroad team. Mine is just an observation for the improvement. There is a room for improvement hereby. There was a story which we had last night of a lady who was diagnosed by the GP. So wouldn't it be prudent on our side, come next year, going forward, the College of General Practitioners should be sending some of the people who are lecturing the GPs to be attending such conferences, also to be getting a chance to meet the consultants who are looking after us over the years, because time is evolving. I remember when we first started NET with Prof. O'Shea in Radisson next to UCD, it was just a handful of us. And now look at us. This is a business which is not going to run out. And I was very sad to see that Adrian had passed on. But that is the nature of the game. Once the light is switched off, you are gone. So we have to improve the system for those who are coming. But even to my fellow patient here, prioritization. I'll just share this to everybody. When you are on a receiving end, it's when you really know when the chips are down. And I had a very, very near-death experience on the 15th of August, where my son is a young adult suffering from diabetes type 1, visually impaired, actually went to a party with other lads after getting the living certificate. The next thing, you are hearing growling next door. The sugar level had gone to 2.5. But our ambulance and the fire brigade, the ambulance was so much slow because there is a lot of politicking, but the fire brigade, lucky for him, arrived 30 minutes. They saved his life. He can tell the story. So for us to get that priority, people, we need that neuroendocrine card wherever you go to casualty. I was in Tala for 3 days before I was transferred many years to St. Vincent. I nearly died. I've been in ICU 4 times, and I'm here to tell the story. Only last year of all the years I missed here because I had to go back to where I was born. But I'm here now, but we need somebody from the College of General Practitioners next year, whether we are going to Galway, whether it's Dublin, whether it's elsewhere, to come such that that lady's life has been saved and she's here to tell the story. That's all.
We understand, it is understood that GPs is the first protocol for a disease. And I know my own GP, when I was diagnosed 2011, and I rang him back to tell him, and he said, oh, that's not cancer. I wouldn't be worried about that. I have a new GP now. As Inca is engaged in this program I mentioned earlier called Think NENS, and that is focused on trying to get GPs to look at our disease, to start thinking about the symptoms that we as patients have, and to raise flags with them that they might then refer us to the proper type of consultants, and that they will suspect a NET. And GPs are, they are exactly in the term general practitioners, right? So there's hundreds and hundreds of rare diseases, of which we are just one. And they are bombarded by us, by other patients, by so many patients, to, oh, look at this disease, you need to know about this is really important, you have to know about it. But when they're hearing that constantly, and they have very little time, as we all know, you don't get much time with the GP when you get in there. So what we need to do is find ways of accessing those GPs, and we need to find ways where they can benefit from looking at what we're trying to tell them. And with the Think NENS program, that'll be a CME, Continuing Medical Education Points. We will be pushing that, when that's released next year, we'll be pushing it in Ireland with the ICGP conference and the collection of GP, their association. And we'll be pushing our agenda as NET patients, and these are the symptoms, this is what you look out for. We'll be informing them that there's a centre of excellence. I mean, they don't know about that. Or, sorry, some won't know about that. And so we have to keep trying, right? Will we get a GP here? If we could, great. But we really need to look at it on this more systemic approach, and we need to try and come up with a program that is better targeted at them in such a way that there's a benefit to them to doing this. They all have to do their CME points every year, as do yourselves here. And so there's a benefit to this. We need to push it. And when the program is ready, we need to push it in the right way that we try and get as much eyeballs onto this disease. And that's what we'll be doing. So I don't know, anybody want to answer anything else?
Just to say, like you're saying, it's an organic process. It's growing. So recently, like Hussein, because he's taken up the NET post, presented at the Grand Rounds, kind of his inaugural Grand Rounds in Vincent's, and that's a wide audience that includes nursing, GP trainees, etc. So it's a process. And it's referred to small 10, a number of years ago, and very big gathering and vibrant. And then the limitations that GPs have, they have 8 minutes per consultation, and that's limiting. So they're the challenges, and we just have to keep doing. I think organisations like INCA, like this network, like these meetings.
Don't underestimate our responsibilities and our power. There's no patient in this room who doesn't have a GP. An awful lot of you in this room are getting an injection every month. Sometimes it's with a nurse who's not used to giving it. You might be the first patient into the practice. So you are an educator, you are an ambassador, and you have a role, and you can spread the word. Just thinking about it as well, looking around this room, I can spot several people who've had a NETS primary in the pancreas. Generally out there in the wider community, and this could apply to GPs as well, people think if you've got a pancreatic primary, well then you're in real trouble. But you're proof that that is not the case. So we are apostles in some ways, and we got to get out there into that community and let it be known that we praise the GP who spotted that person. We let him know that we're thankful to him, and that's our small but important role in the challenge of spreading the news.
I think as well that, exactly as Tommy says, we're all disciples and advocates, and we can push our GPs. But when, going back to this INCA program, when that's available, that gives you ammunition to go back to your GP and say, look, here's something that's available. Spread the word to your colleagues. That is part, in promoting this program as INCA, we'll be doing it from the top down through organizations like WONCA, which is the worldwide organization of general practitioners. Each individual country will do it on their own, like the Irish Congress of GPs. Or also patients pushing from the bottom up and telling your GPs, here's a program, you know, you're dealing with me, but your colleagues mightn't be dealing with any patients, but they need to know about it. And here's a program that can that they should know about and encourage them to do it.
Yeah, I think that's true. And just to add a little bit further, it's a difficult task actually to make a diagnosis of somebody with a neuroendocrine tumor. I mean, even experienced gastroenterologists, so it's a bit unfair just to label the GPs, right? Because I think it's, just to go a little bit further on it, half of the patients that Mark referred to before who had delay in diagnosis with tummy bugs, symptoms, crampy pains and diarrhea, whatever like that, half of them actually were with gastroenterologists as well, like me, right? General gastroenterologists. And they would do a gastroscopy and a colonoscopy, rule out celiac disease, look for, you know, inflammatory bowel disease or other causes, polyps, etc. And they might have a couple of those tests over years, go to a different one. And it's only by doing maybe a CT scan of the abdomen that you might find it, okay? And even sometimes you might do it and it doesn't show up and then it gets a little bit bigger. I had a patient yesterday, 17 years of fairly significant pain, 17 years, right? 64-year-old, and he had a fairly advanced tumor of his small bowel. But, you know, and you see those, but it's hard actually to, I think we can gain a little bit. I'm not sure that we're going to gain major inroads and making a diagnosis earlier. That's I really feel that fundamentally. It's so heterogeneous. So Tommy's saying you've got a small tumor in your pancreas. The vast majority of people now that we see have no symptoms. That's the reality. So we're seeing more and more. Chris would be getting a referral of a patient with a small neuroendocrine tumor in the pancreas that showed up on imaging for another reason. And many of you are in that category. Or, as we mentioned earlier, Derek was talking about, or it was Chris, I'm not sure, about neuroendocrine tumours of the stomach or of the small bowel, where we might take them off endoscopically, etc. So there's a vast array. So the point about the Think Nen is not only to get improved diagnosis, earlier diagnosis. If we can, that's great. If we even gain a little bit, of course, that individual patient is good. But it's the education around GPs in general for NET that this program, I think, is really elegant. In, you know, when you go to your GP, you can sort of say, listen, that guy, Mark MacDonald, had a video with somebody from Uppsala, and they're talking about somatostatin analogs, injections, how to do that, why we use it, the side effects, etc. So they can log on and they can do a little bit of the CME. And there are many, many different videos around the general aspects that you will encounter or your family might encounter. I think that's fair to say that it's a broader education program than just trying to make the diagnosis, I think.
Yeah, I think from Mika's perspective, it's not about the GP making the diagnosis. It's about the GP suspecting it and putting it on the referral net ? And just let, I mean, the GP won't in general make that the diagnosis, but the suspicion is what we want them to see.
Even in patients who are symptomatic, so for an insulinoma, I showed one case of a patient who had a very tiny 1.5 centimeter tumor, which is difficult to pick up on any scan unless you're specifically looking for it. But the average time to diagnosis of a patient with an insulinoma is 8 years. And this is a patient whose blood sugar is dropping constantly. Many of those patients will come from a neurologist where they've been treated, for example, for epilepsy. And they've been on anti-epileptic medication for many years until the penny suddenly drops. The patient's actually eating and finding that because of taking in food, their symptoms suddenly go away. So I do subscribe to the idea that further education of physicians, of surgeons, of medics in general is obviously very helpful. I would also say, though, that in terms of our understanding of neuroendocrine tumours, it's relatively short. I mean, it's in the last 20, 30 years that we're really, understanding far better how these patients should be treated. And Dermot referred earlier on to the ENETS, the European Neuroendocrine Tumour Society, and the fantastic articles that have come out looking at specific tumours of the small bowel and what the standard of treatment for them should be. Nothing like that existed before. If you had bowel cancer 50 years ago, the surgery was the surgery. The treatment, okay, in terms of chemotherapy has changed. But all these other treatments that have come on have really only come on in the last 20, 30 years. There's been pioneering work that originally started with Kjell Oberg, and he gave a very elegant presentation to you in UCC the last time he was here. So this is a relatively, I mean, I'm not saying it's a new disease. It's not a new disease, but our understanding of it is certainly in the last 20, 30 years. And the treatment options in terms of PRT and so on have only developed in the last decade, 2 decades. So I think that there is catch-up that needs to take place. I think as more and more patients are being diagnosed, and forums such as this are, educating a lot of the medics to what's out there and how patients might present and how they should be treated.
I think as well that neuroendocrine disease, neuroendocrine cancer, the incidence is growing dramatically. And I think the 2013 data from the NCRI said, I think it was 4.2 per 100,000, and or maybe even slightly less. And now in the UK, I think it's 8.8 they've recorded. And the prevalence is, even with the prevalence, how many people living with it, and they are, we as neuroendocrine tumour patients have a higher prevalence than pancreatic cancer and several other major cancer types.
We had a clinic, not this week, the week before, and all of the new patients at that clinic were patients who had something found incidentally on a scan that was done for something else. So they had a lung problem, they had a CT scan of their thorax, and it caught something at the top, something funny in the tummy, or something in the pancreas, or something on the adrenal gland. And the scans that we're doing now are so much better than even 5-6 years ago. The clarity in terms of what we're seeing. And I'm not even talking about gallium PET, I'm talking about ordinary CT scans. So part of the increased prevalence is that we're detecting stuff that we just were not seeing 15 years ago. And that's a part of it. And also, these things that we're seeing now that are completely incidental, that we wouldn't have been seeing 10 or 15 years ago, it's almost a new kind of entity within the whole kind of management of this. So and that's why things like the Aspen study that some people here will be enrolled into, do we just need to keep watching these things? Because they might not change, or they might change very little over 20 years, or we need to follow and closely and keep doing what we're doing and get the updated registry, and so it's a process.
We move on to the next question. So.
My GP. So what I was doing now is my GP practice is a UCC training practice. So when new GPs are coming in and they're doing their day inside, I volunteered. So I have done over 40 GPs now that I go in, talk about my experience, and what we're trying to do is that anybody who has a GP practice, that there's student GPs coming in, if you go in and offer to talk to these GPs, what happens then is they can look onto the website, they look up and see what it is, and they're now in the knowledge that when they do become doctors, that they can think of the hoofs, that it's not a horse, it could be a zebra. I've now volunteered to do a new thing, it's a family liaison group where I done it over COVID with Zoom with 2 doctors, where I talk for a few weeks and they get out and they go in and look for information and they come back and talk to me. And we now have 2 new GPs, well, they're student GPs. They're coming to our house on Monday and they're going to meet myself and Owen, and then they learn about it, how it is for a family, how it is for me as a patient, and they'll come back in a few, I think it's a 6 weeks the thing is that they're going to do as part of family liaison thing. So as patients, if you talk to your GP and say, if you have a new GP coming in to do a study, I will go and talk to them. I will tell you my experience, and then that GP might picks up somebody. It could be 5 years down the line, it could be 10 years down the line, but they know that this is the knowledge. They can look at the website, they can get the information, and I think if we all work together that we could get more information out there and help, say, somebody in 5 years' time that will get a diagnosis better.
Go ahead.
Just this is going back to a question that was asked earlier on about admission and length of time in A&E. From a very personal experience, a consultant admitted me to hospital within the last 3 weeks or so, told me to go through A&E in the Mercy Hospital, in Christo's Hospital, and within 5 minutes of arriving in the building, I was already in a bed, admittedly in the A&E, next day transferred to the ward. While it may be pure accidental, but it was a reality that I experienced, and I'm grateful for it. Plus the fact that back in 2002, when I was initially diagnosed with the carcinite in another hospital here in Cork, it took them 15 days of continuous testing within the hospital complex to come up with the answer to the question. Now, I don't think it takes 15 days today. All the time, my information was being fed to a team led by Christor. 17 years later, Christor, as he said himself, told me that I had only 13 days to live, where gangrene was just about to set into the stomach. This may seem a mutual congratulations to Christor and his team, but I think a lot of things have come a long, long ways. And this is where now the question of the GPs. I am fortunate the GP that I have at the moment is a personal friend of Derek Power. So there's a quick liaison between Derek Power and my GP. But if I have to go to a third-party consultant, I have to actually advise him, open the web page here and then. And this will explain to you, because I couldn't waste time or your time explaining to you what the carcinite, etc., is all about. So there is a lack of information at ground level. I've come across dietitians recommended to me by hospital consultants to treat it. I have to spend the first maybe half a dozen meetings with that dietitian explaining that this food is high fiber, definitely it shouldn't be taken. So there's an awful lot of ignorance somewhere, and as the lady said, we all can be witnesses, advisors, educators of the educated people. Because we've been there, we've even got the T-shirt.
I know lots of you here have been to Uppsala or maybe thinking about treatment abroad, and it would be a missed opportunity if I didn't ask Catherine, who's here on our panel, just to update you on how the Uppsala system has been working, because there are a lot of clients and possible repeat clients here too. Catherine.
Thanks, Tommy and Mark and everybody. There really is no update. The system continues to work as it has been working over the last couple of years. So your application with your referral letter from your consultant, the National Cancer Programme worked really closely with us. So we have a system where applications to Uppsala or applications from any of the recognised doctors consultants on this panel get automatic approval, which means that there's no delay in getting approval, getting your forms, and then you just send in your appointment dates. So I suppose, again, just to say there is no difference. We hope it's working perfectly, but if there are any problems, to let us know. Now, Mark did mention to me just quietly there earlier on about the availability maybe of services in Northern Ireland. and certain patients may wish to access those. And if they do, I'm not familiar with them. And unless we're kept informed about new developments, I can't comment on them. But it is really important that we're included in any discussions that are going on. So some of these, I have 5 schemes that we operate, and in a recent meeting with the Health Pricing Office, they happened to comment that the schemes that we operate are the equivalent of a small hospital. That's the number of patients we're putting through going abroad. Some good, some bad, whatever. But what is difficult is that while we're seen as handling as many patients as a small hospital, we're not included in any of the hospital meetings, so we can be isolated. So just don't think that if something is slipping through the cracks that it's because we're ignoring it. It may be that we don't know, so tell us. Okay, thanks.
Abroad, while PRRT is coming up to speed in St. Vincent's, then the system continues as normal, and patients will be fair. I think Tommy or elsewhere was said that more healthier patients might make the trip abroad, and those who are more in need can't travel, maybe handled through Dublin.
Again, that's down to the significant cooperation and engagement with the consultants that have been managing your care, because they talk to us and they say to us, look, we may not have enough gallium scans, or we may not have enough PRRT, or there may be specific patients that require to go abroad in the interim. We will facilitate that. Just because something is available here, if your consultants tell us, look, that there's an interim period that needs to be covered, we will cover it. And again, it is down to your consultants engaging with us. That's what makes it easy for you and easy for us.
I think that's just to reiterate something that I mentioned earlier, maybe the same touched on as well. I mean, so the phasing in of PRRT therapy in Ireland in a safe and effective manner will take a little bit of time. We want to do it in the right way, just like they do it in Uppsala or other places, with a very stringent protocol. So so we're just starting the journey with that. I think ethically it's a little bit difficult to say that because you're fit and young you go to London or to Uppsala, and you know, taking on patients initially that are a little bit frail and fragile, they're not necessarily the best candidates for us to start with either. So please bear with us. We are not doing it in isolation because Chris is involved, Eric and Greg down in Galway. There's a big panel of us with the NCCP. So we're trying to be equitable, right? But we want to, when we take any one of you on that might need it, you know, hopefully you don't, but down the line, you know, that we do it in a proper way, and it's going to be sort of well managed, and that's the important thing. Despite the fact that we're a very small country, like I said, to actually be able to work out how the patient interacts with the community afterwards, holding on to the patients to do that special scan to measure the toxicity, dosimetry it's called, etc. All of that pathway has to work out. And, you know, we've got to integrate within the acute hospital settings. So our beds, for example, the beds might be used for ordinary ED admissions. And we sort of said, we want to ring fence those beds because they belong to us. We fought for it. We had to get the money for it and all the rest of it. And gee, I was really annoyed. But then we didn't have the therapy up and running. You're not going to deny a poor, you know, my relative, for example, who might come into ED, the chance of coming into that bed either. So there's equity across the whole system. But there are a number of little issues that we have to sort of iron out, but thankfully it's up and running, and we'll do it progressively. I just want to say, Catherine, thanks again for being so understanding. I think I don't know if the CAR T-cell program, there was a question actually in CAR T-cell as well, there was somebody had, but I don't know whether the CAR T-cell program was phased in. Maybe you might comment on that gradually as well, please.
Okay, so the CAR T has become available now in James's and at a recent meeting about CAR T. So we will continue to support CAR T going abroad. CAR T is an unusual one because it is, and I'm going to speak openly here, it is so expensive. We're talking kind of €500,000 per treatment. an application to the Treatment Abroad scheme, the cost of the treatment is not part of the criteria. But this particular treatment, because it's so expensive, requires sign-off above the Treatment Abroad scheme at national director level. And there are some types of CAR-T that are still not available in the country, and those are continuing to be supported to go abroad, thankfully.
And just again, from a patient's perspective, if you're scheduled to get PWRT treatment and there's a wait, it's not because your clinicians aren't pushing for it, are pushing hard enough. It's not that Catherine is blocking it. The reason sometimes is because at the other end, the provider, the Uppsalas, they have to schedule you and they have other patients as well. But what we have achieved as a group is every doctor you see in this group and their colleagues, if they sign a form and they say Mary or John, wherever they're from, requires this treatment, that's enough for Catherine. Catherine will do the administration on it. She's not going to say, are you sure about that? She moves ahead with the administration. So if there is a bit of a delay, small delay, it's because of the scheduling on the other side. And that's something that we cannot improve. But from our side, it's as perfect or as good as it can be.
So, Hussein, maybe you'd like to tell people, where does lutetium come from? And, you know, it's not a simple matter of having it on a shelf. The lutetium that's used in PRRT.
You mean about supply issue? My voice, because the radioactive material come with a very short expiry date because decay, you lose the radiation, so it has to be used immediately, and obviously we are this one's better. It has to be used immediately, usually on the same day, maybe maximum the next day, and obviously this was a lot of discussion happening in the background, you know, when we were setting up the center with the provider, with the company who provide the lutetium, about the supply and the supply agreement, etc. So, for example, for that reason, we can't do treatments on Monday, and usually we'd prefer the treatment to be mid of the week, and not only with us, for the other centers as well. So yeah, there is some issues with that, but limitations.
So, any more questions from the audience?
Has there any test been developed for testing for nets? Particular test. I hear a load of people only find out about this accidentally, like we did. And is there a particular test that can be done to indicate that you have this condition?
So there are very many different types of net. And this is where the whole, I suppose, education of suspecting it. So based on your, you know, you've heard Christopher talk about somebody who was attending a neurologist because they were having seizures, but actually it was a low blood sugar and an insulinoma. So somebody has to think about it. Then there are some genetic forms in the setting of multiple endocrine nets, where you can test a family member to see if they have the gene, and then you can screen them with very specific tests for that. But there really isn't as yet a single test that you can go in and have and say, this is a net. You would have to suspect what type of net it is and then do the tests.
Thanks, Mark. Hi, everyone. Thank you for a really informative day. It's been really, really wonderful. And thank you all for being here. I know everyone's here on their own time. Just in relation, Donald, to what you mentioned there about the genetic bit, my mum was diagnosed. She had it a long time by the time she was diagnosed, but she lived, thanks to yourselves, for a further 11 years, and she died in October 2020. But my aunt, mum's sister, was diagnosed inside the last 2 years. Now, it would never have entered our heads about the genetic connection. And then this weekend, I suppose it was the first time that I looked at the INCA card and seen the genetic bit as well, and that it is rare. But is it something that as a family and others maybe should be considered and be considering about getting tested? And what do you think about that? Like, is there it likely, or is it a complete coincidence? Thank you.
I might answer that. So I met a few of you earlier asked me about the same question. So there are a few things that might point that the neuroendocrine tumors is a genetic. For example, if you have multiple tumors in your pancreas, if you have high calcium, etc. In these cases, we might think about a genetic as a cause of that. And then usually we start by testing the patient. If the patient is positive, then we'll go to the family member. But usually they are not genetic.
Yeah, I agree with that, but I'd add one little thing, and that's right. So there's a constellation of tumors, benign and malignant tumors, in an individual patient with a genetic abnormality. Mark mentioned it, Derek, and then MEN1, multiple neoplasia type 1. So you get the pancreas, you get little benign tumors of the parathyroids, if you like, that secrete calcium, and we also get ones in the pituitary. They're the main ones. Or you get other things as well. That's what we call a genetic inheritance, that if I have it, I've got 1 in 2 chance of passing it to my children. I've got 2 kids, so statistically one of them will have it, right? If you've got 4, 2, so that's the way it is. If you've got your mum and your aunt both with it, and your aunt is still alive, I would suggest that you would come to us and we'd talk about that, but I would recommend genetic testing, yes. Because even though they may be elderly, more elderly than you, they're the generation before you, there's no reason as to state that MEN1 could not be sort of slightly in that family. It's possible. And there are a few other even rarer genetic conditions that can happen. And small intestinal neuroendocrine tumors, for example, we've been asked about this before and we've spoken about it before. You won't remember. I remember it because it's very specific. There are a couple of families around the world with small intestinal familial forms, okay? We never do it for any of you here with it. Tommy has a small intestinal tumor. There's no family history of it. We don't do that, and because it's sporadic. It happens by chance, we don't know. But there are very few small little pockets. But when it occurs in a small cluster like that, we'd go through that in a bit more detail. So it might be pertinent to do genetic testing in your specific case. All right?
Another question from the back.
Is regarding. Hi, sorry, my question is regarding the gallium PET scan. So from what is roughly the wait time if you're told you need one? Is there an average wait time?
I think that's a great question. What I would say is there is a wait time, and the wait time in this country is too long. There's no doubt about that, and it is preoccupying the people sitting up here very much so. In fact, some of the discussions that we've been having outside the meeting is how we can improve that. The wait time at the moment is months, and it is a basic scan that should be done for patients who are diagnosed, not everybody with NETs, but certainly probably 90% of patients with NETs. It's a staging, it's part of the workup before you have an MDT discussion, before you plan the treatment of the patient. Up until fairly recently, many of you will have had octreotide scans done or octreotide scans done. But the reality is that gallium PET scanning is by far a much more accurate way of diagnosing and staging the tumour. And it should be the standard of care for everybody. At the moment, there are 2 centres, both of which are in Dublin, one in St. James's and one in St. Vincent's, and there are problems accessing that. It's not just for patients outside of Dublin, it's for patients in Dublin as well. We are hoping, and I have to say your patient advocate, Tommy, has been working very hard behind the scenes with the support of Dermot and Ristardo Leda to improve access and to open up further centres for this around the country. It's expensive, but it is critical that we get that going, and we're certainly hoping that very shortly we will be in a position whereby we can do gallium PET scanning here in Cork. But the wait times for this are simply too long at the moment, and we're absolutely aware of that.
Could you say more about why they're so long? How much money is needed? Can we do anything to talk to Untouched after today was so successful? What can we do to...
I've handed a business case to the Taoiseach today. We know how much it costs. It's not astronomical, but it is expensive. It is possible to get this up and running, for example, in Cork. I've spoken to, and myself and Derek have spoken to 2 of our radiology colleagues in the Cork University Hospital who are more than willing to get it up and running. I've given the business case this morning to the Taoiseach. That's where we went. I think this is going to happen. I think all of us up here are aware of this. I think the issues regarding St. Vincent's Hospital perhaps are best addressed by Donal and by Dermot. But do you want to maybe speak towards that? No. Okay. Well, I can't answer for St. Vincent's. I know James's are not really using the gallium PET scanning for NET patients. It's predominantly for prostate cancer that it's been used for. It is an issue. We are trying very hard to address it. I'll be very honest with you. I'm totally and utterly frustrated with sending patients for this scan and waiting, on behalf of the patients, waiting for a long time for these scans to be done. Sometimes you lobby, and even with lobbying, it doesn't. I mean, if you lobby for your patient, some other patient is going to be delayed longer than that. It's a funding issue, but I think it will get addressed very shortly. I do think we'll have the facility here in Cork, and I think they are trying very hard. I mean, Dermot and I know Donal are trying very hard to overcome some of the difficulties that there are in Vincent's for access for that. But it is a critical staging investigation to be done for every NET patient, or 90% of NET patients. So it is a big issue, and it's being addressed. That's all I can say.
Yeah, it's been ongoing for a long time, and we thought we'd have not a Pandora box actually when we got it on board in Vincent's, but the reality is that a PET-CT scan is used for many different reasons, and the other one that's frequently used is FDG PET, and that's also, there's an awful lot more people involved in sending people for the other scans than there are for the gallium scans, so we're fighting a battle. I always said and advocated at the start that it would be, you could have one, if you only had one PET centre doing gallium for the whole country, you could make it work on a business plan, and I'm sure you could do that. But it's hard to do that in Ireland. So you're fighting with many different things. So if you had one, for example, if you said a PET centre in Athlone would just do gallium PET-CT for our NET patients, sure, wouldn't it be wonderful? You know, you could get a train up, or you could go meet halfway, or somebody drive you. It doesn't take long. It's not a long scan. You get an injection, an hour later you have your thing. We've tried hard to work with that, and hopefully, you know, on the strength of this meeting and lobbying again, not only with, of course, Taoiseach can only do a certain amount, you know, he's listening, of course, but at least he can try to, but in the key, like Shane was talking about, and trying to prise it open a bit. What's important is Richard gets that as well, and he does get it, but he gets a little bit of a leverage from, you know, our discussions together. That's important.
I'm sorry that the session this morning was so long, but the reason we had it the way it was structured was to make our push for gallium scanning. That was politics you saw in action there. That was diplomacy. That's what we're about. We don't fight with people. That was the man who's in charge of the National Cancer Control Programme. That was the Taoiseach, who's a former Minister for Health. One of the reasons he's here is because we're in Cork. And I'm listening to the voices from around here. That's a voice from Abbeyfield. I saw somebody here from Mallinhead who looks healthier than last year, as you do from Abbeyfield, since we were here in Cork, and that's great. Don't for a second give up. Like PWRT has come, the Centre of Excellence has come, Treatment Abroad has come. In the scheme of things, gallium scanning is going to be easy. Don't get impatient with it. We're going to get there. One of the reasons why, and you can't really get angry with Vincent's over this, because it's a wider thing. If you're a young radiographer and you're working in South County Dublin and you're trying to pay rent on a house, it's hard nowadays in Ireland. That's nobody's fault in this room. That's just, you know, that's a consequence of growth and house prices. So what we can't do is we can't give in, we can't despair, we can't get frustrated. We'll find ways around it in the meantime. Access will be given not because of friendships or pull or money. Access is being given on a basis of need, which is the only way to do it. But we're going to get there. We had a fantastic 15 minutes in the room behind us during Mary and Owen's session. That was why today was devised in that way. And hopefully in 12 to 24 months, you'll see gallium scanning here. And if it's in Cork, and if it's cheaper to do it in Cork because of the bigger picture in Dublin, sure, we'll all come to Cork. If we can come from Mallinhead to a meeting like this, we'll come. And if we get a second centre, we're going to double the output. So we're going to get there. So just stick with it. And most importantly, these people are on our side.
Can I add to that, though, that you know, the access to the gallium scanner is not controlled by Dermot or Donald or Hussein. It's a part of the radiology department at St. Vincent's. And access to that, we've had, as a patient group, meetings with Richard Aleda and Stephen Skeen, who runs radiology in Dublin. And it's given on need, on medical need, and assessed by the radiology department. So, you know, the requests from Christor, the requests from Dermot, from Donald, they go through the same process. I know it may feel, for us as patients, it may feel, oh, the Dublin patients are getting access and we're not down in Cork, or whatever it may be. And I'm sure when if and when it comes to Cork, it'll be a similar process of need and not based on geography. So I just think we should understand that. We want to obviously get our scans as quickly as possible and have no problems, but you know, life is not like that, but we're doing the best to try and improve the situation. Any more questions at the back of the room there?
Hi there. This is our first year attending this event. My husband was diagnosed in July. We heard the word cancer and you think, Christ. Then they say neuroendocrine and you go, what's that? And then they say it's rare and you think, oh, that's it, there's no hope. We were very lucky. We have a great GP. It was actually our local Mallow hospital, the consultant there, that pushed for further tests, and biopsy came back with the neuroendocrine. We're very lucky that he's under the care of Professor Power. I suppose for us, we were very nervous coming because just didn't know what. I've never ever attended an event like this before, and we didn't know what to expect. But I suppose we leave here more educated. I've got the websites and stuff that we can actually read proper information, not this Google, and then you read all these big words and you can't understand it. And when you don't understand it, you fear the worst. So I suppose for us, this was great. Even though it's a huge gathering, it feels very personal. And I suppose we all have a voice as well, that we can speak up and say what we want or lobby for what we feel we should have. And we're just very thankful to have this here in Cork this year. So that's all I want to say. Thank you very much.
Any more questions? We're glad you're here, by the way.
Hello, I was just wondering, is there a dietitian attached to St. Vincent's Hospital that you can access, especially for NETs? Because I feel that, you know, taking the medication now, particularly say Creon, and coming up against a few problems, trying to actually speak to a dietitian about that. I was told I'd have to get my consultant to do a letter to see somebody privately and this, so I'm just wondering, is there somebody special for NETs?
Yeah, sorry, we do have a service. Her name is Ellen, and usually, you know, the referral will come through one of the NET consultants when you'll be seen in the clinic, and she could organize to see you either, you know, as face-to-face or through phone consultation.
Thank you very much for that. And in relation to that last question, I have a question as to, because I've never seen this mentioned on the website. I'm aware that Creon is used as an assistant to help absorption, but I don't have a pancreatic neuroendocrine tumor, but I had in the small intestine, and I had all these discomforts related to the somatolene autogel injection. And I have started using ordinary digestive enzymes, which are available in a health food shop, given to me on the advice of a physiotherapist, and I found them extremely helpful. And I'd just like to, if you have any comment to make on that, I take one before breakfast, 2 before main meal, and 1 before an evening meal, and I have found it extremely helpful. So I offer that to the panel.
Yeah, if I can talk to that. So the digestive enzymes that you got through the health shop, they're kind of a cousin of Creon. That's what Creon is. So, and some people who have had their pancreas removed obviously need to take digestive enzymes, Creon, with their meals. Some people who start the somatolene autogel or any of the somatostatin analogues have zero problem with their bowels, and others need Creon sometimes in the few days after the injection, maybe the first week, and then they're fine for the 3 weeks after. But you should certainly trial it to see if it makes a difference. And what the dietitians are very clear about, you know, your pancreas will release digestive enzymes as you eat. So you should take a tablet at the start of a meal, a tablet a quarter of the way through the meal, another tablet 2/3 of the way, and then a tablet just at the very end. And some people need to take up to 6 tablets with meals to get benefit. Some people find they take the Creon and it actually doesn't really help. So then you will stop taking something that doesn't really help you in general. So yeah, it's an important part of the overall management for some people. And the dietitian's also very clear in the advice they give. For some people, eating can be a problem that precipitates some pain, and they will have to find a meal pattern that suits themselves. We'll often say little and often. So don't go to the 3 big meals, because that won't work for you. Have what you like when you feel like it, and that can be cornflakes at 6 o'clock in the evening. You know, you don't have to be prescriptive, because at 6 in the evening it should be a sandwich or my main meal.
just on the point that, you see, Ellen is new now, relatively new in dietetics, because we had somebody who was there for, 4 or 5 years, who came and had addressed a meeting. Yeah. And of course, it takes a while for people to get to understand neuroendocrine tumor patients and all of the different varieties and somatostatin analog. And it's one of the things that Tommy said, because these are often young people, they move on, they go abroad, etc. So it's hard to get the full multidisciplinary team always together. Hopefully Ellen will stay with us. Now she's young, and then you have people like that. They go maternity leave and all that sort of thing. So it's actually it's always a constant struggle for us to get the whole thing right. But again, education and the self-education and dipping into the website, calling up some of the people who are experienced with this, sharing the experience that you've just done with this gentleman here, that's all invaluable as well, so we can ask the questions as well. So I think that we give as much as we can with the dietetic advice when it's available to us. I don't know if it's available in Cork. I'm sure it is as part of the Pancreatic Centre. But don't be afraid to ask the questions and reach out to the friends in the room as well.
And a few years ago, you mentioned we had a talk from a dietitian who was in St. Vincent's, Deirdre Burke, yes, and that was recorded. It's on our YouTube page. If you don't know that we have a YouTube channel, go to our website. You can get onto it from there. And nearly all of our meetings have been recorded. There's lots of questions like this that are there with answers for them. And one of those is about the diet, the nutrition, and I think it's the most watched one of it. And great. And if I remember, one of the great points she made that people said, "Oh wow," it was don't take it with tea, take it with water. That was really important, and people found that improved the benefit of it. Sorry, so we have another question. We're going to be finishing up very shortly.
Hi everyone. I had mid-gut resection about 4 years ago, and I spoke to the dietitian, and the normal stuff, the advice you're given, and I was on Creon, and I found that it's a very personal journey, because a lot of the foods that I was advised I could eat, I couldn't, and I could eat some of the stuff that people were looking at and saying, you can't be eating that. And I was taking more and more Creon, and I suppose once or twice I forgot my Creon. And I thought, you know what, I'm not any worse. And so I kind of decided I'm going to have a go at this. So I reduced it by one, and then I reduced it by another. And I was actually much, much better. My system was working way, way better. So I don't take it anymore. And I eat a little bit of everything. Maybe one or two exceptions, but I eat a little bit of everything. But my problem is I can't put up weight, Yeah. So, but other than that, it's a very personal journey.
And I think that's a really very good point. It is everybody's journey is different. Everybody's story is different. Everybody's reaction. So we start medication because we know that 70% of the time it will do what we expect it to do. 20% of the time it won't, and some of the time it does the opposite. So you're now describing that you felt unwell or less well on the Creon, and that will be the case for maybe 5% of people. And your approach in gradually reducing it as opposed to cutting it, very sensible. Yeah. Yeah. Yeah, so.
Thank you for making the point about it being a very personal journey. Just in the same way as we're ambassadors and advocates, we also have an opportunity. It's one you can't really avoid. You have to manage your own condition, take a certain amount of responsibility for managing your own condition. I was nudging Hussein here a few times to say, will you talk a little bit about diet and Creon? Because I sense there's a bit of questioning going on out there. I was on it. I think the Belgians put me on it, or the Swedes put me on it years ago. But I was also on Nexium. And I found that I was going around with all these goddamn tablets, and just the kind of person I am, I said I'm going to try and give these things up just to see does it make a difference. And I did. But there about 3 months ago, I was having digestive problems, you know, the runs and stuff like that. And I just said, maybe I should go back on the Creon for a while and see if that makes a difference. So I asked for it to be prescribed, and I have a stash of it, and I'm maybe going to start putting my toe in the water with it again. So that's the way it works for us sometimes. One other point to make, from, say, an event like this, you know, the information is shared. Like, I met people last night who didn't know the way we had been advised that when you're getting your injection, that now the advice is to maybe leave it out the night beforehand for 24 hours at room temperature. That's what a lot of people have been doing for a long time, and they're finding that the injection is going in that bit easier. Some people don't know about that, but I know there are a lot of us in this room who have been doing that, and it has been working for us. And, you know, the brilliant thing about information being shared, when we were having the chat about Creon and not taking it with tea, Dermot said, Jesus, I didn't know that about tea. So every day is a school day for us all.
There was a question that we got earlier by email about complex liver surgery happening in Ireland, and how did that compare to abroad, and are we not doing as much as abroad? So I don't know if you had a comment on that.
We had our reassessment for our ENITS kind of Centre of Excellence, and Shell Oberg actually came with, didn't he?
That was with IOR.
Was it? Anyway, basically our activity across the various treatments is in line with all other centres, whether that is pretty much. Dermot, do you want to?
Yeah, I think that when we have the opportunity to look at complex liver resection, we do, because we've got access in Vincent's anyhow to superb people like Donald Maguire and Amir Hoshi, for all the surgeons there. I mean, and initially it was Justin, I suppose, was leading that from the neuroendocrine tumor point of view. You remember him very well because he was always here in the panel every year, and we'll invite him back next year. Actually, I think we should. He's such a good friend, and always a smiley face as well, despite a lot of difficult procedures that he's had to do over the years. Look, I think that even occasionally we're part of the UK and Ireland transplant group for NET, potential transplant group, so we even look at that option occasionally. We haven't done it that often, but there are a couple of patients that might be benefiting from that. I mean, somebody very young, etc. It sounds like radical, doesn't it, to do a transplant for somebody with cancer, and it's very hard to do that with committees, ethics committees and all the rest of it, but it is being done, and we're part of this group looking at prospectively analysing this area, and it still is done. So it is considered, and it's done often. I mean, people have quite a few resections, and even sometimes, Christopher mentioned about taking out some of the liver without taking out all of the disease. We call that debulking surgery. And sometimes we do that as well to control the disease progression and to get good harnessing control, so that the PROT or the somatostatin analogues, or, you know, if one part of it's just growing a bit too fast and it's not having the desired response, sometimes we might tailor therapy to certain aspects of it. So I think it's available to us, no doubt.
Any more questions?
It's more a statement than a question. I was diagnosed last June by accident. I had no symptoms leading up to it. And my initial reaction was, I never heard of an endocrine tumour. So I was very fearful. And I went along met the relevant people after the diagnosis and had surgery. But when I went to my GP, he had never met a patient with an endocrine tumour. So he said, this is new to me, tell me what you know about it. Now, I had read up on it, I had looked at the various websites, and I had some informed meetings with 1 or 2 people who had experienced endocrine tumours, and I had everything written down, and I typed it up and printed it and handed it to him. So the next visit when I went to him, and later when I went to get my injection, he called the nurse in from the medical centre and said, this is Mary, I'm the patient Mary, and the nurse was called Mary. She has an endocrine tumour, I want you to listen to what she's going to tell us. So in my last injection, there was a new doctor there, and he called in and he said, oh, you're the lady that came in and told us all about endocrine tumours. I've heard of it before, so it worked well. But I had an experience on the 1st November, I was in Vincent's Hospital waiting for a scan, and there was a lady came in, she was next appointment, and we were chatting for a few minutes. And she said to me, what treatment are you on? And I said, I'm getting Sandostatin LAR. And she said, I'm on something, but I can't remember it. I'm so afraid of what I have. I can't remember the name. And I said to her, you have to stop and think. Like, I'm no expert. I was afraid when I was told, and I was very nervous because people would look at you when you'd say you had something wrong. They never heard of it, and they look, are you sure you have something wrong with you? You look fine. So I was saying this to a few people yesterday evening. It's my first time here, and I got great confidence out of hearing that most people in this room have had that experience, whether they were diagnosed last year or 10 years ago, talking to somebody, members of family or friends or acquaintances. It's like, I never heard of that, and they fob it off. So I think really we have a lot of control within our own powers to be positive about the diagnosis. And whether it's the GP or a neighbour or a nosy neighbour or just somebody asking a question, bidding the time of day, to explain it to them, that they'll know it's something of a nature that needs to be aware of, and the next time they hear it, that they will be wiser and handle it. And on a personal note, having come here today, I'm delighted to have been part of listening and meeting people, and I'd like to take the opportunity to congratulate everybody, medics, the organisers, the hotel, everyone, and it was a pleasure to meet all the other patients and family. Thank you for having me.
I'm tempted to stop on that one, but I know you've one more. We'll take one more question, yeah?
Hi, I'm Gillian. I came in late to this. I came in for a coffee and saw the sign, so I popped in. I was diagnosed with NETs in my colon by my cecum just in August, and I have to go apparently urgently to James's for that gallium scan. And did you say that it's only primarily used for prostate? So does that mean I'll be waiting a long time for it, number one? And then when I had an MRI after the surgery, when they removed everything, they found 2 spots in my liver. So when I do go for the scan in James's, and maybe Vincent's would be another option, I don't know, will they be able to tell if the spots in my liver is a neuroendocrine tumour, or what's the story with that? Thanks.
Yeah, that can be depends on the type of tumor. The gallium PET-CT doesn't show all neuroendocrine tumors. That's the first thing. It's not really competitive. It's a different scan. It's not gallium tracer for prostate is different, so it's not the same one. Okay, and it's not competing for just prostate. It's not really competition. Let's say it's you know, there are other type of PETs, as I mentioned earlier, FDG PETs for other types of cancers, etc. I don't know how long you'll be waiting. James's, we've sent a lot of patients to James's, but the waiting list was seem to be as long as others. But where are you being referred from? Okay, so you're from Cork then, yeah. Yeah, hopefully it shouldn't take too long, but I mean, I can't say, to be honest with you. Yeah. No, I mean, it depends on the primary tumor. I think you'd have to talk offline about it, but it's not 100%. But if it's we call the more classical neuroendocrine tumors, they tend to light up. and it depends on the size. There are a few other parameters that are involved, you know, but yeah. But it's a good indication.
I'd just like to say to you as well, it was unlucky that you were diagnosed, but it's so fortunate that you just happened to be passing and saw you won the watch because you have come into your community here. We are your family, and we are going to provide you with the help and the information to help you, get a handle on this.
Last question.
What I want to speak about, or it's just a suggestion really, is about the awareness. And we spoke about talking or letting GPs know about the awareness. But I would like to think that could also let pharmacists be aware of neuroendocrine tumours. Like I was diagnosed 3 years ago, and when I put in the prescription for the Somatuline gel, it was the first time the chemist had to order one in for me ever. And my pharmacist hadn't a clue, or didn't have a clue of the reason why I was taking the Creone tablets. Actually, she asked me the reason why I was taking the Creone tablets with the Somatuline gel. Now I know it's sort of you're trying to get GPs to be aware of diagnosis of neuroendocrine tumours, and it's baby steps really. But I think we should also try and emphasise and letting pharmacists know of the treatments, or what treatments are the effectiveness of them. And also with regards to, just to let people know, I was sort of very lucky that when I got my first Somatuline gel, that the drug manufacturing company sent out a nurse to show me how to self-administrate it. And she went through an awful lot with me and made me aware of some side effects and what to do if I did have side effects. And she also provided me with, because I've been speaking to other people who have never experienced this with from the drug manufacturing company, a nurse company. She also provided me with a disposable bucket for the syringes when done, and provided me with a telephone number for a company who would come to your house and take away the bucket when it's full. So just to let you know that. Thank you.
On that topic, I'm just going to ask you a question. Like, I know in other territories, there's a generic drug that's coming out or in use. Is there anything happening with that in Ireland?
Not that, no is the answer. No.
Good.
But I think that's really good. I mean, the nurse service has been always really enthused by the number of patients who are now self-administering or partner administering. We had a patient yesterday who came and is heading off to New Zealand in January and just starting injections, and it was just, they had previously given themselves injections after, orthopedic surgery or something like that, just, the molecular or low molecular weight heparin to prevent clots and stuff like that. So they were just bowled over by this, that the nurse is going to come out, and so it's great because they're able to bring injections with them to go on. They're going on a boat for a trip, and it was just post-retirement, and that's fantastic. So reach out for that service. It's the Ipsen group that provide that, and I think it's great. And the additional, of course, little gems that you hear about how to manage the injection, taken out from the fridge and all the rest of it. I would just say though, Tom, you're not going against what that advice was for the overnight. If you're not having problems with your syringes with the injection, stick to what it says on the carton, because there's a small risk it might denature if you leave it out overnight. I mean, 2 or 3 hours might be absolutely enough, because once it comes to room temperature, it might just work. But just to say that, there might be, if you left it for 12 hours, for example, it might start to degrade a little bit, so just be careful with that one.
But also Tommy's on the Sandostatin LAR, and the other one is the Somatuline Autogel, and are they different? Should they be handled differently?
Well, they're a little bit different. I mean, the Somatuline, you know what, I'm not in favour of one over the other. And some people may have a little bit of side effects more on one than the other. The self-administration of the new syringe form of the Somatuline is a little bit easier that people find. But look at, I mean, look how well he looks. Am I going to go against that? Never better.
Okay, I think we've really run over. I think we need to finish up. I appreciate if there are other questions, and I'm sorry that we can't be asked. We've had I think we've had a fantastic day. It's been really, really beneficial. I want to thank the doctors for giving their time. I think, as it was said, I mean, they don't get paid for this. It's their time off, and they're here. And they come every single year, always here, and always the question and answer sessions that we have are always so they're so engaging, and they're so helpful, and it's an honest discussion backwards and forwards, and not aggressive. And I think we all benefit from that and learn so much from it. There's one last thing. We had those bowls. We're going to give out some more because we bought them. Actually, I should say it was Adrian Haythorne-Twait, who was a member of our committee. He organised the bowls and plaques, and sadly he passed away in January. And he had done this as a way of thanking and acknowledging all what the doctors do for us. So in memory of him, we want to make sure that we deliver them now. Mary and Cleena were going to present to Derek and Christor. Fortunately, they've had to leave, so they're not here. So you'll do that offline. Everybody sitting in here got their bowl last year. But we do have some bowls we would like to have, if you wouldn't mind taking them with you, to give to Stephen Skeen, Rachel Crowley. I thought there was one more. I'll have to think about it. Mark Doherty, yes, Mark Doherty. So, yeah. So I'm going to give you those to take with you, if you wouldn't mind. And also, we have Adrian organised a plaque to be put up on the walls of the hospitals. We did this during the year with Catherine in the Treatment Abroad offices in Kilkenny. And it's just an acknowledgement of our thanks for what you do, and to put it on the wall. So we're going to present the plaques now. Maybe Mary would like to do that, if you wouldn't mind, Mary. So that's what Adrian organised. It's a plaque, and it says, the hospital, in this case St. Vincent's University Hospital, Centre of Excellence for NETs, with gratitude for the expert care of NET cancer patients and their families, NET Patient Network. It is last year our 10th anniversary. We have that for CUH, for Galway University Hospital, for the Treatment Abroad. So please present it to Donald. So I also want to thank Paul, Michelle and Sean, who are doing the recording the event. So they did that for us last year, and by the end of the day we had the recording and we were able to upload it onto YouTube. So we'll do the same, I think, Paul, Michelle, today. So we'll get it up, it'll be available to watch. And on the YouTube channel, you go back and look at all the other conferences that we've had like this, and all the questions that were asked. It's a trove of information, really great information. As I said earlier today, there was also with the eNetSync webinar, really good information with the roundtable discussions worth looking at. So thank you all for a fabulous day. We're not finished. We have lunch in the restaurant here. So hopefully you filled in your form earlier about what you want. But we have the restaurant to ourselves. Everybody's welcome. Please come down yourselves if you have time. And then we'll talk about, as a committee, we'll talk about where we're going next year, if it is back to Dublin or if it's to Galway. hopefully you can all make it again next year. And thanks to everybody. Thank you.